If someone has an acute neurologic change or an acute deficit, such as the inability to speak, some word finding difficulties, weakness, I would err on the side of caution, and always better to assume it's a stroke and not have it be one than to downplay it, say it's not a stroke, and then 2 days later find out it was a stroke that could have been treated.
Welcome to Living Real Change, a podcast from Piedmont Healthcare. I'm your host, Dr. Lacey Knight, Chief Health Information Officer here at Piedmont. Join us as we highlight the people, the stories, and ideas that are transforming care and strengthening communities across Georgia. From inspiring patient journeys to expert health advice, each episode offers insight, hope, and a closer look at what real change looks like in healthcare today. Today we are joined by Dr. Michael Stiefel, a board-certified neurosurgeon at Piedmont Atlanta Hospital. In this conversation, we're focusing on stroke care and how it has evolved. He shares how stroke care has changed over the years, moving from simple treatments to modern tools that help doctors quickly understand what is happening in the brain and decide the best way to help. Dr. Stiefel talks about how Piedmont works together across hospitals to make sure patients get the right care fast. He explains why strokes are more common in the southeastern United States, what recovery can look like, and how new ideas and innovations may help even more patients in the future. It's great to have you here today.
Well, thanks for having me.
As you know, I'm an emergency physician, so I still remember in the beginning of my training when stroke treatment was aspirin, and then maybe we added some blood thinners, and fast forward a few decades, and we've got really pretty sophisticated technology that helps us detect somewhat early whether or not patients would benefit from endovascular procedures, that helps us make decisions around transfer. Maybe you could talk a little bit about how technology has influenced how we make decisions around stroke treatment.
I think you hit it right on the head. The way we treat stroke has changed over the last 10 to 15 years dramatically. You had asked about how we kind of triage patients. Currently, we use an array of CAT scan studies to evaluate the patient. In addition, obviously, to a person like you, the ED physician who's at the bedside, we image the patient. First, we get a non-contrast CAT scan to see if there's blood or no blood, and that helps us delineate what type of stroke it may be, because there's two main types of strokes. And then if it's an ischemic stroke where a blood vessel gets blocked, which is the most common form of a stroke, about 85% of people have an ischemic stroke, we then go on and look and do some more advanced imaging. We obtain a CAT scan that looks at the blood vessels themselves. That's called a CT angiogram. And then that helps us determine if a major blood vessel is blocked off. We can see that blockage. And then in some cases, we get what we call a CT perfusion, because that helps us look and see if the blockage is actually damaging or reducing blood flow. So we use all of these studies in concert with each other to help us triage patients to the right facility.
So a lot of really advanced diagnostic technologies to figure these things out. And then the treatment options have gotten a little bit more sophisticated. Can you maybe talk about the non-interventional kind of standard treatments that are offered, and then even the interventional types of procedures that someone with your expertise would offer to stroke victims?
Currently, 2025, the current standard of care management for someone that presents to the hospital within last known normal within 4.5 hours would be intravenous thrombolytic medicine. Many of us know this as TPA. More recently, there's been a newer drug that we've started using called TNK, and that tenecteplase is the current drug that we use. Both are effective. TNK is a little bit easier for the clinical team at the bedside to use. It's given in a single dose. And so that's the standard of care, even with the techniques that we have available to us. Patients that present within that time window still are going to be getting TNK. If TNK doesn't work, or you're not eligible for TNK for whatever reason, then we have a host of endovascular devices that we can use. The most common procedures that we perform are either aspiration thrombectomy, where we take a catheter up and we just simply suck the clot out, and so we aspirate it almost like a vacuum cleaner. And then there's mechanical thrombectomy, where we go up there with a stent retriever, which is a stent attached to a wire, so the stent doesn't stay in the patient. It's just up there, and it helps grab the clot, and then we pull the clot out. So both have been shown to be equally effective.
Are these things that are available at every hospital?
They are not. Within the Piedmont system, we have 3 hospitals that perform ischemic stroke therapy. We have Piedmont Atlanta, which is one of the comprehensive stroke centers in the Piedmont system. We have Piedmont Augusta, which also is a comprehensive stroke center. And then Columbus. Also, Columbus performs the ischemic stroke treatment. It doesn't treat some of the advanced stroke diseases like aneurysms or AVMs.
Would you help walk us through how a given hospital would decide what types of treatment options make sense, when patients need to be transferred, and really how that kind of coordination between hospitals that are able to handle more complex diseases or conditions versus those that are a little bit more limited in what they're able to take care of? How does the decision to transfer work, and how does the coordination work?
That's a great question. Something that I think Piedmont excels in. If you look at stroke systems across the country, I think Piedmont excels in the coordination of care amongst all of its hospitals within this large health system. So the first thing we do, obviously, is we get the CAT scan, and then the decision, which is to decide whether to transfer or not transfer, is really it's not unique. It's not something that I decide or my partner decides. It's very recipe, so to speak, very protocolized. And so the ED physician at a remote hospital is following the same guidelines that I'm following at a major comprehensive stroke center. So the things that we look at, again, are the severity of the stroke. We look at whether the patient has a blood vessel that's blocked off, that's amenable, whether they meet the time window. Every hospital in Piedmont utilizes a AI imaging software platform that reconstructs imaging. Those of us that are at the comprehensive stroke center, we're able to see that imaging on our phone. We're able to see all the imaging that goes on at every hospital in Piedmont. So that, in conjunction with the neurologist and the ED physician that's at the primary center, we all communicate either by phone or on the app itself, and then that helps at least get the ball rolling, so to speak. Once we see that a patient's eligible, sending hospital would then talk to us, and then we would either fly the patient or drive them directly to our operating room for emergent procedure.
How often does that happen? Is it something that is pretty frequently people need that type of care, or how does that look from your perspective?
Yeah, it's becoming more and more common. Unfortunately, we're seeing at least in our program an uptick of strokes. Right now, we're currently performing this procedure approximately 250 times a year, and so yeah, it's a good number.
That is quite a bit. When I first came to Atlanta, someone introduced me to the term of stroke belt, which I had not heard before. So, can you maybe tell me what that means to you, and maybe even why that name is given to this region of the country?
Yeah, so the stroke belt, I refer to Piedmont Atlanta as being in the buckle of the stroke belt, and so anytime I give an outreach talk, that's how I refer to us. So the stroke belt is a well-documented, well-accepted term within the CDC and the American Heart Association, and it is comprised of the 11 southern states, all of those within the South and Southeast. The reason why we call it the stroke belt is there is a higher incidence of stroke for people in this region compared to the rest of the country overall. Probably an extra 5 to 10% increased stroke rate for those people that live in the stroke belt.
Maybe you could provide some insight into what that seems to be attributed to, or what the thinking is.
Yeah, I think most of us break it down into access to healthcare, the style of living, the type of food. I think everything feeds into itself. There are a lot of areas in the South that are very rural, and so their access to healthcare is limited. Their access to healthy food is limited. That access and the desire for activity, exercise, things like that are also limited. So when you put all these together with regard to reducing the risk of stroke, they all are compounded. And so all of those variables individually may not be a big deal, but when you add them all together for a single individual, they do add up.
We talked a little bit about technology and how we make the assessments for strokes, and what the blood flow looks like, and making decisions around transfer. But I think one thing that may be important to talk about is really how the telestroke programs fit into even that initial evaluation. I think that may be something that is a little bit unexpected for patients when they're coming into any type of facility, but it's pretty common, wouldn't you say?
Yeah, telestroke is becoming more and more common. If I look at the course of my career, the fact that even comprehensive stroke centers utilize a telestroke model, I think it's becoming the norm. mostly because having physicians that are capable of being at the bedside 24/7 at every hospital is becoming virtually impossible. There aren't enough physicians.
Would you take a moment to just explain what a telestroke program is?
Sure. Telestroke is where a physician would be remote. They could be anywhere in the United States. They could probably be anywhere in the world. And basically, what happens is we have a team at the bedside, which is usually the emergency room physician, the nurses. And when they recognize a stroke, they activate what we call a stroke alert. That gets the local resources alerted, such as their CAT scanners, the laboratory, things like that. So they're ready to receive the patient. And by activating a stroke alert, they actually call to our teleprovider. And some places use a robot. It physically looks like a robot. Other places use a computer with a webcam, similar to like what we're doing today. And that camera is focused, it's a high resolution camera and it's focused on the patient. And the physician who's on the other side of that camera has the ability to look at the patient's chart, look at their vital signs, their laboratory values. They're able to look at the CAT scan imaging that comes up. And they're also able to use that camera to help perform an exam. And with the team that's at the bedside, together they perform a very accurate neurologic exam to help feed into the algorithm for what the next step would be. And so that that would be the kind of the pinnacle of what a telestroke program would be.
Thank you for the explanation. There's a lot of technology that's really impacted stroke care over the last couple of decades. How has that impacted the outcomes for people that are suffering from strokes?
It's helped. So we have a phrase in the stroke world called "It's time is brain," and that's a mantra we stand by. All of us stand by that. So the quicker we get to a patient, the quicker we can intervene, the better the chances are that they're going to do better. Now, there are people that I can treat within an hour of their stroke, and unfortunately, they don't do well. But if you look at stroke as a whole, we know that the quicker we can evaluate a patient, the quicker we can get them to the right facility, and the quicker we can intervene, the better the chances are of a good outcome. So all of that taken in concert is what helps a patient's outcome improve.
When you end up taking care of one of these patients that require one of these endovascular procedures, either the two types of thrombectomies that you'd reference, what is the typical recovery like? What's that process like for people that end up undergoing those types of procedures?
That's a great question. So it takes a team, it takes a village, which we're very familiar with in Piedmont. We have a portion of the care of that patient, but it's definitely not the complete care of that patient. When a patient is sent to us, oftentimes they come directly to our emergency room from a helicopter. The flight team brings them directly to the operating room. We perform our procedures with the patient under general anesthesia. We have full anesthesia support, anesthesia standing by, waiting for the patient. The anesthesia puts the patient to sleep. Then once we're done, they go up to the intensive care unit, and then they're slowly taken off the breathing machine as they wake up. But a lot depends on the severity of the stroke. There are some patients that are making amazing recovery, and they are able to be discharged, some to home within just a few days of having a major stroke. Others require a little bit longer care, and some are discharged to rehabilitation. And then with inpatient and outpatient rehab can also slowly improve. Recovery from stroke can take anywhere up to 18 months. It's definitely not something that occurs immediately.
So you touched a little bit on here. I want to make sure we haven't missed anybody, but with even a large health system as we're in, there's only 3 of these kind of more comprehensive sites that manage these types of sicker patients with strokes. And I heard you talk about one, you need specialized training from neurosurgeons like yourself. You need an intensive care unit that's capable of taking care of these patients. You need a strong anesthesia and perioperative team. Also seems like you need the ability to accept complex transports some way. What other things are necessary, or that kind of infrastructure that we sometimes maybe take for granted to be able to offer this type of service?
Think of it like running a NASCAR team. There's the driver, but it takes the whole team. So we'd be remiss to not include the nursing staff, respiratory therapy, nutrition, physical therapy, occupational therapy, all of the case management. All of those are vital. The neurologists that help manage the patient once they leave the intensive care unit, internal medicine, cardiology, all those are important. The infrastructure to receive a critical patient again, is having, we have an operating room that is readily accessible to the flight team. We have dedicated nurses and techs that are on call just for stroke with a mandatory response time of less than 30 minutes. If anyone lives beyond that 30 minutes, they sleep in the hospital when they're on call. Anesthesia provides availability 24/7 for us. And so, yeah, it does. It takes a complete team to be able to take this patient from home to at one of our other hospitals, whether it be a primary stroke center or an acute stroke ready hospital like Mountainside, take them by helicopter directly to Piedmont, Atlanta, and then navigate the stroke process.
That's a pretty amazing, I think, commitment from a variety of different team members to make sure that this is available to the community. So that's pretty neat to hear.
Yeah, it's an honor and a privilege to be a part of something like this.
Well, thank you for being part of it too.
At Piedmont, quality care changes lives. Meet Tom, a lifelong medic who suddenly suffered a stroke at home. Tom was diagnosed, treated, and in surgery within minutes, thanks to seamless coordination across the entire care team.
I've seen firsthand how every second counts. When I needed help, Piedmont moved with speed and precision, and that saved my life. A week later, I was back at home with my family, back to work and back to living.
Hear more at piedmont.org/quality care. Piedmont, real change lives here.
I'd like to move into, maybe this is more aspirational conversations, but I'm curious, with all of the types of technologies that we're seeing today, what are you seeing that is maybe emerging technology? It might be in the AI domain, but what do you see as that kind of space where there's either the greatest opportunity to make improvement, or what's coming down the pipeline in stroke management?
So we divide ischemic stroke up into large vessels, small vessels, and that's the acute stroke treatment. And then there's the subacute treatment. So with regard to the major cause of stroke, large vessels that are blocked off, we do a pretty good job of getting them open and restoring blood flow. We have a success rate of restoring blood flow, greater, pretty much 93 to 95% of the time, we're able to restore blood flow to an acceptable level. That being said, even despite opening the blood vessel, patients may still have a stroke. If you look at what the future and kind of things that we're looking at, we call it upstream, expanding the indication, maybe extending the window beyond 24 hours with advanced imaging. Can that help us treat a patient beyond 24 hours? Can we treat vessels that are a little bit smaller? Maybe not just such a large vessel, but do we have catheters and techniques that can help us get into smaller vessels that may be blocked and cause a disabling stroke? As you can imagine, the smaller the vessel is, the more risky it is for us to navigate in that vessel. Some of these smaller vessels that I'm referring to are on the magnitude of 1.5 millimeters. So a 1.5 millimeter vessel blocked off can still cause a major deficit if it's on the left side of your brain. It could prevent you from speaking. So how do we get there safely? And then there's recovery. I think we're all familiar with things that are going on with the brain-machine interface, Neuralink. So I think that's that's on the horizon. Part one is recognizing it. Part two is treating it in the acute stage. And then part three would be getting them, in that subacute stage. What can we do to optimize that recovery?
Is this an area where you're using robotics?
The robotic interest has come in and out of vogue with regard to endovascular. So for us in robotics, it would be setting up a robot remotely, where maybe it's time sensitive, where we couldn't get someone here fast enough. So maybe someone that was, let's say, a hospital that's 200 miles away, 300 miles away, and there's no way they can get to a stroke center within 2 or 3 hours. Are some robotics being developed that I would be able to, with the help of a team at the primary site, but robotically be able to navigate my catheter. So that's come in and out of vogue. That hasn't been adopted as mainstream yet, but that's something that people are working on.
Broadly speaking, what advice would you give to patients and families that are trying to navigate these complex kind of neurosurgical procedures around stroke?
Well, unfortunately, these all occur when we're not expecting it. This isn't something that, people go from one, can get second opinions. This is time sensitive. I think, be educated on what the signs and symptoms of stroke are. Obviously, have your loved one take good care of themselves or best they can. But I think if someone has an acute neurologic change or an acute deficit, such as the inability to speak, some word finding difficulties, weakness, I would err on the side of caution, and always better to assume it's a stroke and not have it be one than to downplay it, say it's not a stroke, and then 2 days later find out it was a stroke that could have been treated. So again, we also, in the stroke world, would rather over triage someone than under triage. So assume the worst, hope for the best. Get your loved one to the closest hospital, call 911, and let the doctors there, the team there, coordinate the care. But that would be my recommendation. Don't assume it's nothing.
Well, thank you. Any additional thoughts you'd like to touch on related to your areas of expertise?
I think just social awareness. I'd be remiss as a part of the Piedmont family, I'd be remiss to not give a shout out to Piedmont. I think as a healthcare system, it's committed to the healthcare and stroke care of the people we come in contact with. Each hospital, as I mentioned, is set up exactly the same. And so whether you present to the emergency room at Piedmont Atlanta or whether you present to one of our remote access hospitals, you are triaged and evaluated the exact same way. You have a teleneurologist or a local neurologist take care of you. You get the advanced imaging that you need. Doesn't matter that you're not in Atlanta. So I think that's a powerful message and commitment to the care of stroke that Piedmont is dedicated to. And I think I'd be remiss to not give everyone at Piedmont a shout out for that support.
Thank you for listening to Living Real Change. To hear more stories from across Piedmont Healthcare, be sure to subscribe and watch for upcoming episodes. For additional health tips, news, and resources, visit us at piedmont.org/living-real-change.